lecture today. Today we will be talking about, we are moving away from your endocrine topics. Now we are going into hematological topics. And the first lecture is talking about bleeding disorder. Oh, it's not mute. Oh, it's not mute. All right. Okay. So I hope you guys went through the video that I sent you guys yesterday. It's yesterday. Yeah, yesterday. Today morning. Sorry. Because that video give you a very nice graphic and demonstration explanation of our normal coagulation cascade. So, for bleeding disorder, what you guys need to know is what is a normal clotting mechanism, and need to know the basics, the few types of bleeding disorder that is common in our population. And in this lecture, you need to know what are the important history, particularly related to bleeding disorder, and how do we investigate and approach to bleeding disorder, and how do we manage in acute bleeding event. Alright, so if you haven't go through the video, you can feel free to go through again during your revision time. Okay, so why does this bleeding disorder important? Because even in dental, there are a lot of procedures involving or has the risk of bleeding. Okay, that's why it's important to you, especially when especially when there's a planned invasive dental procedure, because there's potential risk of causing bleeding, and you need to know why the patient is bleeding, and at least need to know what are the risks that causing the bleeding, and how to manage if there is an acute bleeding episode, what you need to anticipate. All right. Okay. So these slides summarize our basics coagulation cascades. So we have primary and secondary hemostasis here. So what do we mean by primary hemostasis? Means that initially when you have a cut, you have a simple superficial cut, endothelium get injured. So immediate endothelial injury will followed by a platelet plaque formation. All these are because release of cytokines, inflammatory markers. All these will attract the platelets. Platelet basic itself is very sticky to the injured endothelium. So you form your plaque at the endothelial leakage here and try to plug the hole by forming a platelet plaque. And the platelet plaque will subsequently trigger the beginning or initiation of secondary hemostasis that involve trigger of coagulation factors involving the intrinsic extrinsic pathway, and in the end, this secondary hemostasis will form a fibrin clot, and this fibrin clot is something more secure and to plug off the hemostasis. Okay, this is something more complicated. You're not expected to know, but the video has a very good explanation of how it happened. Okay, you do not need to remember. For medical students, for dental students, you do not need to know this. You just need to know what is primary, what is secondary hemostasis. But last time when we in medical school, medical students need to vomit out the whole intrinsic and extrinsic pathway, because it's very important to understand coagulation. So you look at it. For secondary hemostasis, it involves different coagulation factors to form a fibrin clot. So we have intrinsic pathway and extrinsic pathway. Both are triggered. Intrinsic is triggered by the collagen exposure, and the extrinsic pathway is triggered by the damage to endothelial tissue. All these trigger the chemicals or inflammatory chemicals to activate the tissue factors or coagulation factors. All these coagulation factors, majority are produced by your liver. So you have a liver problem, automatically your coagulation factors will be affected. It can be increased, it can be reduced. And if you look at it, the most important factors I want you to remember is factor 8 and factor 9, which is in the intrinsic pathway, because these are the two conditions that's inheritable. that is like hemophilia A and hemophilia B. Hemophilia A is factor 8 deficiency, and hemophilia B is factor 9 deficiency. So you have inheritable bleeding disorder. Most commonly, one is von Willebrand, number 2 will be factor deficiency, which is factor 9 and factor 8. Okay. And then both of these intrinsic and extrinsic pathway, in the end, you will activate a common pathway where they will activate your factor 10, factor 10A, and finally, it will change the fibrinogen to fibrin. And this form a mesh-like fibrin clot to stabilize the bleeding point. Okay, so you look at it. You look at the picture here, A, hemophilia A, and then you have von Willebrand disease. In von Willebrand disease, you also have a factor 8 deficiency. And in hemophilia B, you have a factor 9 deficiency. Vitamin K deficiency also will affect your factor 9 because vitamin K activate a few coagulation factors. One of it is factor 9, right? So this is one of the most important mind map or graph you need to remember for these slides. It summarizes basically everything you need to know. If you don't know what the other slides, just remember these slides will do for your exam. Okay, so know about the different causes of bleeding disorder. So this is divided by different etiology. If you look at this, so our coagulation factors, our hemostasis require platelets, require von Willebrand factors, require clotting factors. So what causing bleeding? Cause number 1 will be coagulation factor deficiency. You don't have coagulation factor, you can't form a clot. So the most common that we have here will be hemophilia A and hemophilia B. Okay. Hemophilia is X-linked disease. Anyone know what is X-linked disease? Have you guys heard of this term?
Only male affected.
Yeah, theoretically, only male is affected because means it's inherited on our X on our X gene. Female is XX, male is X and Y. So meaning that this defect is carried on the X gene. Means you only have in male you only have one X. Means that if you have one of the defect gene, automatically you will be having hemophilia. While female, you need to have 2 defect gene to be affected. So most of the time, if a patient the female has one of the defect gene, you only be a carrier. You will not be having the disease, unless you are so unfortunate. You have something called inactivation syndrome. One of your X get inactivated, then you will have hemophilia, but it's very, very rare and uncommon. Okay, that's for coagulation factor deficiency. Next thing more common will be platelet disorder. Platelet is something we measure in our full blood count. We have hemoglobin, white cell count, and platelets. And platelet is very important in our primary hemostasis. Whenever you have a mucosa injury, you bite yourself, you have a scratch on yourself, the first thing that will stop the bleeding will be platelet, because platelet is circulating in our body and immediately you form a plaque and try to stop the bleeding. So what can happen to the platelet? Platelet can be reduced in number. You do not have enough platelet, you have easy bleeding. That's called thrombocytopenia. So what can cause thrombocytopenia? Can be congenital or acquired. Inheritable low platelet is not so common. It's not to say very common. One of it will be von Willebrand disease. Okay, and acquired can be drug-induced or liver disease or chronic alcoholism can causing low platelet. So how does liver disease give you low platelet? Anyone, any idea? Actually, I think it's mentioned in the video. So in liver cirrhosis patient, they have hypersplenism, and because of the hypersplenism, some of the white cell and platelet they get stuck in the spleen. They call sequestration. So all this will lead to low platelet count. But usually the platelet will not be too low. Probably around 50 to 70,000. So because of the hypersplenism, patient get low platelet count. So problem the platelet can be low count, or it can be problem or disorder with the quality itself. Okay, it can be the platelet can be non-functional or immune activated by the immune system, causing DIC. When this sets in, the platelet does not function normally. So other less common causes of bleeding disorder would be vascular disorder. The vascular structure of the vessel itself is not strong due to underlying defects. Number one would be scurvy. Scurvy is due to what?
Vitamin C deficiency.
Yeah, correct. Scurvy is due to vitamin C deficiency. So making the mucosa or the vascular structure is not strong enough, so easily your vessel get ruptured. You have easy bleeding. Then another thing is hereditary hemorrhagic telangiectasia, where your vessel wall is tortuous. You have easy rupture of vessel causing bleeding. Cushing syndrome as well, excess in cortisol. Remember Cushing syndrome, keep on coming up in the slides. So Cushing syndromes it causing the structural instability, the vessel wall is weakened. All this lead to easy bleeding as well. Same goes to Ehlers-Danlos syndrome. It's also an inheritable disorder whereby patient has a collagen disorder. The vessel is easily ruptured. Okay. So but the most important thing you need to remember for bleeding disorder that's relevant to you will be coagulation factor deficiency and platelet disorder. Coagulation factor deficiency can be due to hemophilia A or hemophilia B for congenital causes. In acquired causes, you can have deficiency in the factors due to warfarin use or due to liver disease. Right. So the following slide is more like a repetition or explanation regarding this classification of bleeding disorders. So you can have vessel wall disorder due to the scurvy, due to Cushing syndrome, Ehlers-Danlos, and also the Oster-Weber-Rendu disease. Okay, platelet disease. The commonly that we see here, acquired causes can be due to ITP and also TTP. We will talk in details in a while. Then for coagulation factor deficiency, hemophilia A, hemophilia B, and also von Willebrand disease. So how do you know someone has bleeding disorder? A lot of time patient, if you look at it, our patient does not come into you, knock on your door, say that, see, I have deficiency in the factors. So most of them, majority of them, that present with a bleeding episode. Okay, because our normal either with a bleeding episode or incidental finding on your full blood count. In our full blood count, you can detect the platelet. Sometimes we do routine screening, they noted the low platelet. That's how they get referred. Meanwhile, for other bleeding disorder like hemophilia, does not present like that because your coagulation profile, your INR is not in your common health screening blood results. So majority of patients with bleeding disorder, they comes with a bleeding episode. Can be from very mild due to mucosa bleeding, persistent mucosa bleeding after a dental distraction or after scaling episode, or they have a persistent bleeding, easy bruises, forming bruises, a lot of petechia, ecchymosis on the limb, or they may even present after a fall, they have a bleeding in the knee, hemoptyrosis, or they can get referred from elective surgery. After elective surgery, the bleeding non-stop. That's usually how it get referred to us. So whenever you get referring of bleeding episodes, a thorough history is important to let us guess uh, what's wrong with the patient. What kind of bleeding disorder are we dealing with? You guys still here because it's heavy rain here?
Yes,
Am I
doctor,
still
can
clear?
hear.
Am I still clear?
Yes,
Oh, okay.
yeah, clear.
Okay. All right. So, um, so most common they come to you. There's a bleeding episode. So you need to ask about what sort of procedure was done during this episode. Is it is it a huge operation, or is it just a minor operation like a minor dental extraction that the bleeding didn't stop? So focus on this current episode, number one, and then number two, you want to ask any previous bleeding episode or not. So you have to really ask from the moment they are born until now. So what do we mean by moment of their born? So a lot of inheritable bleeding disorder like hemophilia, the bleeding happen immediately, uh, especially with those very severe hemophilia. So you want to ask the mother when they are born, does the baby develop any bruises or easy bleeding, especially from injection site. So when you are born, you'll get vaccine immediately within hours you are out from your mother's womb. So you'll get the IM injection of vitamin K, intramuscular injection, and then you get your BCG vaccination, and you will also get hepatitis B vaccination. So if you are having inheritable like hemophilia, if you get an IM injection, you get bleeding, you get bruises. So those are the things that you can ask the mother, does the patient has a bleeding episode like that or not? And when they are in their teenagers, when they are childhood, do they have easy bruising? Do they have swelling here and there after an easy fall? So those will give you an idea. Uh, has there been a heritable or inheritable bleeding episodes? Then of course, family history is important here. Why? Because of the X-linked inheritable pathway. So you ask anyone else in the family has a similar bleeding disorder or not. So you want to ask, does the uncle, especially is the maternal side uncle, does the maternal side uncle has any bleeding, any bleeding episodes, any bleeding disorder in the family tree? Okay, and then you also want to ask any medical history. Does the patient taking any antiplatelets and warfarin, any anticoagulant prior develop these bleeding episodes? Okay, so those will be important to know. Okay, so examinations, you want to look for evidence of bleeding. So how do we? So you need to know what are superficial and deep bleeding and how they present. So purpura, what is purpura? They are red or purple spots on the skin. Those are bleeding in the dermis layer. So how does it differentiate between the purpura and also normal macular rash? So they do not blanch with pressure. You have an allergy. If you try to press on the skin, the redness will disappear. Those are blanchable. But in the purpura, with the superficial bleeding, the red spot does not blanch with pressure. Okay? So if the purpura increasing and coalesces together, those are called ecchymosis. If the petechia is big enough and forming a bigger clots like this, those are called ecchymosis. Smaller lesion is called petechia. Larger lesion is called ecchymosis. Commonly, it can be seen petechia will be in the extensor surface. Ecchymosis as well will be in the lower limb as well, in the area that easily get minor trauma, especially at the ankle area. Of course, mucosal bleeding will be common. You need to, in the history, you want to ask any recurrent nasal bleeding or oral bleeding after brushing teeth. Then check the mouth, looking for petechia, looking for minor bleedings in the hard palate and also in the soft palate. And also have to look underneath the tongue as well, any bleeding or cuts from the tongue. Okay. All right. Then another thing that wasn't in the slides would be hematrosis. Hematrosis means bleeding in the joint. After the patient had a fall, they may complain of severe pain and swelling in the knee. In that case, you want to suspect any presence of hematrosis, bleeding in the joint. Because hematrosis is something urgent. You need a surgical washout to prevent the joint injury. Okay. Other causes of the bleeding disorder. Just now we talk about coagulation factor deficiency, and now vascular suction defect due to vitamin C deficiency, the scurvy. Because of the low vitamin C, it can cause defect in collagen synthesis. So patient has an easy bleeding. Usually this bleeding will be mucosal. Same goes to Cushing syndrome. Too much corticosteroids causing atrophy to the connective tissue and make the vessels easily ruptured. Okay. So again, Cushing syndrome slides keep coming out. Know the at least 5 features of Cushing syndrome. It will definitely help with your exam. So moon face, muffler arm, thin skins, easy bruising on striae on the abdomen, and osteoporosis. Okay, for Ehlers-Danlos and Osler-Weber-Rendu syndrome, all these are due to collagen deficiency and causing easy bleeding. If you don't remember this, just forget about it. It's very rare. I myself never seen one of these before. Okay. All right. So same goes. Next will be a platelet disorder. So low platelet order abnormality with the platelet quality. Okay. Quantitative or qualitative disorder. Quantitative means thrombocytopenia, low platelet count. Our normal platelet count is 150 to 400,000. Anything less than 150 is low. Can be due to reduced production from the marrow or due to hypersplenism. In liver cirrhosis, your spleen get enlarged due to portal hypertension. So you have increased sequestration. Because the spleen is enlarged, your blood vessels have to flow through the enlarged spleen. So some of the platelet can get stuck in between there and get sequestrated. That's what we mean. So because of the sequestration, your spleen, your platelet get destroyed in the spleen. That's why the number get reduced in liver cirrhosis. And you have poor quality of the platelet. Qualitative platelet disorder can be due to defects in the platelet reaction. It can be due to ITP. It can be due to vitamin deficiency like B12 and folate deficiency causing impaired production. Sorry, this slide is about the causes of acquired thrombocytopenia. Why does the platelet count get low? It can be due to poor production, not enough production from the marrow. Commonly, it's due to vitamin deficiency that we've seen will be B12 and folate. And you have immune thrombocytopenia purpura. It's idiopathic causes. Some patients just have a sudden production of antibody against your platelet, and this causing low platelet count. Okay. You can get increased destruction due to consumption, due to infection, DIC, and also due to ITP or even drug-induced thrombocytopenia. Okay, so management of bleeding disorder is very simple. It's basically just replace what that you do not have. You do not have enough platelet, you replace the platelet. You do not have enough coagulation factor, you replace the coagulation factors. Okay, so now we're going into the other bleeding disorder, which is hemophilia. All right. So the most the common congenital coagulopathies that we've seen will be hemophilia A and also hemophilia B. Hemophilia A is the deficiency of vitamin is the factor VIII deficiency. Okay, It's X-linked recessive disease, so commonly it just affects the males. Female, most of them are carrier. Okay? So they present with a more significant bleeding. That they don't present with the mucosal bleed. In the coagulation factor deficiency patient, they tend to present with a deeper cut or deeper bleeding site, like hematosis, bleeding in the joint. They can have bleeding in the urine, can present with GI bleeding, can also present with the bleeding from laceration. Another thing, they can present with bleeding after elective operation as well. After von Willebrand disease, hemophilia A will be the second most common bleeding disorder. Okay? Then usually they can further class into a mild disease, moderate disease, or severe disease. In milder form, you cannot. They will only present with the bleeding, wound bleeding after a minor procedure. Hemophilia B is due to factor IX deficiency. The presentation and symptoms is very similar to hemophilia A. So management for hemophilia, if they're having bleeding, you need to give a factor replacement. Okay, we can have a specific factor 8 and factor 9 replacement. That is for newer treatment. Well, long time ago, when there's no specific factor replacement, FFP is something we can use, or in your district hospital, in the small places, you do not have a specific factor replacement. You can give fresh frozen plasma and also cryoprecipitated. So those are something you can do when there is a severe bleeding. Of course, now we rarely use because of the risk of hepatitis B and C or viral transmission. Okay, von Willebrand disease is one of the most common hereditary coagulation abnormality. Okay, so there are three types of von Willebrand disease. Type 1 is due to a partial deficiency. You just have not enough number, but you still have it. So the disease is the milder one. Type 2 is a qualitative defects. You have the number of von Willebrand, but it doesn't function very well. Bleeding is mild to moderate as well. Well, type 3 will be a more severe form of von Willebrand disorder. They can present with a deeper bleeding because of the total absence of von Willebrand. So the symptoms of von Willebrand disorder can range from easy bruising, mucosal and nose bleeding to a deeper bleeding as well. Okay. Usually very deep bleeding or internal bleeding intra-aort will be uncommon except type 3. Because type 3 you have a complete deficiency, and due to the complete deficiency of von Willebrand, your factor 8 may be affected as well. Your number of factor 8 will also get reduced in type 3 von Willebrand. Treatment for von Willebrand disease, you give desmopressin or you replace with the platelets to control the bleeding. Okay, so another causes of bleeding is due to DIC, something I think you wouldn't see in your practice because patients will be very ill in the hospital. So in DIC, it's called disseminated intravascular coagulopathy or coagulation. So it's due to it's something what we call consumptive coagulopathy. So because of the severe sepsis, there is a sudden activation of coagulation cascade everywhere. So because of the activation of coagulation cascade, so basically all this will happen in the small capillary, small vessels. They activate coagulation cascade. So you form small clots in all the small vessels in the body. So because of these small clots, perfusion to the peripheral get reduced, and too many clots use up all the coagulation factors, and because of that, you have easy bleeding due to the deficiency from the consumptive process. So underlying disorder associated with DIC, you have a severe sepsis most of the time, severe infection with multi-organ failure, so we will trigger activation of coagulation everywhere. So it causes fibrin deposition, causing microvascular clots everywhere, and lead to reduced perfusion and organ failure. And because of the consumption of these platelets and coagulation factors, you have deficiency of these factors, and you tend to bleed. So you form a vicious cycles, forming clots and bleeding at the same time. That's what happened in DIC. But in DIC, patients will be very sick. You usually don't see them in outpatient setting. All right. So in DIC, what we do is treating the underlying sepsis, underlying condition, and replace the coagulation factors like the platelet, FFP, and cryoprecipitate. And when patients develop DIC, usually their prognosis is very poor, and the risk of death is very high because of the multi-organ failure. Okay, so go back to the most important slides if you are lost in between the lectures. So the past 20-30 slides just now, we were going through what are the bleeding disorders, what are the causes for bleeding disorder, including coagulation factor deficiency, which is hemophilia A, hemophilia B, and Mobili-Brand, and also the platelet disorder. Okay, these two is less commonly seen. Okay, so now go to how do we investigate coagulation disorder. So there's only two tests you can send in your basic setting, which is your full blood count. You're particularly interested in the platelet number and coagulation profile, where you will see proton mean time, your PT, activated partial thromboplastin time, your APTT, and INR. Usually this is the test that you will commonly see in the basic setting. If you suspect patient has a hemophilia, and then you proceed with a specific clotting factor assay, like factor 8 or factor 9 level, or 1 milligram factor level. This is only available in a tertiary or big center. Okay. So how do we approach this? If patient are bleeding, what do? We send off full blood count to look at the platelet count and the coagulation profile. So if the platelet is low, then we will think this is thrombocytopenia. So then we think what is the causes of the low platelet. So it's very straightforward. And then if the patient has a bleeding, we also do a coagulation profile, and we look at the PT, APTT, and also INR. In prong APTT, we will think of hemophilia. We will think of hemophilia A or hemophilia 9, A or B. Then we will do, if it's still prolonged, then we'll do the factor assay level. Okay. Any questions so far on the investigation? So for your level, I do not expect you to know the flow chart of this. For you, it's very simple. Know that when patient bleeding, there's two blood tests you need to know: full blood count and coagulation profile. So if the platelet count is normal, then you think of other bleeding disorder. Then you look at the coagulation profile. If platelet is low, then the problem will be your platelet due to thrombocytopenia. And then at normal number, then you refer out to the physician to work out what exactly is wrong with the patient. Okay, any questions so far?
No, doctor.
Okay, then a little bit on how do we manage the bleeding event. Okay, basically, then depends on what types of bleeding you have. You have a mucosal bleeding or superficial bleeding. You can just apply direct pressure on that wound. If it doesn't work, then you can apply you can, if your direct pressure doesn't work, then see whether you can apply a tourniquet or not. If you can apply a tourniquet, you put above the wound. If a tourniquet is not available or you can't put a tourniquet, then you have to put a topical hemostatic agent with direct pressure. So let's say you have a cut, you're bleeding, you apply pressure. So you can either apply the pressure directly on the wound to press on the vessels. If it doesn't work, then you form a tourniquet above the cut. Alright, so if you know there's a disorder with the bleeding, so what do we do? So basically, a lot of time we'll be treating the number to stop the bleeding while we wait for further workup to find out what is the underlying cause. So when the platelet is low and patient is bleeding, then we transfuse the platelet, regardless what is the cause of the low platelet, because patient is bleeding, so we don't have time to find out is it due to DIC or is it due to ITP, is it due to hemolysis. There's so many causes, but right now you are bleeding, patient is bleeding, and you need the platelet to form to stop the bleeding. So we usually transfuse the platelet. Same goes with the deranged coagulation profile. Okay, we suspect patients having hemophilia, or we do not know. A lot of time we can give a FFP replacement to temporarily stop the bleeding while we working out for other causes. Okay, and if you suspect patient with DIC, everything is prolonged, then we give a DIVC bridging. Okay, so something more relevant to you will be before the dental procedure. You need to know there's a patient on antiplatelet or anticoagulation and how long to withhold them prior to procedure. I think for dental, specifically for dental procedure, are you guys having a specific lectures regarding this? How long to withhold antiplatelet and anticoagulant? Because
I'm not sure about this, doctor.
I think you guys should have this because it's specific, different guidelines compared to medical. In fact, in dental, I go through there is different countries that different sets of guidelines on how to manage these anticoagulant prior to procedure. But the basic concept is very similar in medical procedure. So I think this is taken from Malaysia guideline regarding the anticoagulant. There's one page is talking about anticoagulants during dental procedure. So same goes with medical or surgical procedure. Usually we will divide them into the risk of bleeding, be it no risk, unlikely to cause bleeding, low risk of causing bleeding, and high risk of causing bleeding. So that's how we class them into their risk. Then we decide whether to stop the anticoagulant or not. Okay. So I think all these are more familiar with you. I think you guys definitely will have a lecture regarding this because for dental procedure I will not be very familiar. Okay, this high risk procedure I think is very easy to understand. The patient will bleed if you do this procedure. Of course, you want to stop your you need to stop your anticoagulant and antiplatelet totally prior to procedure. But procedure that is unlikely to bleed, a lot of time you can continue or you stop 1 or 2 days beforehand. But I think as the exact duration you need to clarify with your college and need to double check with your dental guidelines. Okay, so but things that you need, the concept you need to understand how long to stop the anticoagulant and why that duration. So rough guess, why do you think that the duration to stop for each anticoagulant or warfarin or antiplatelet, why is it different? Anyone know why? Like if you look at this graph here, antiplatelet, you have to stop 5 days beforehand, and then for warfarin, usually it's 5 days as well, and for DOAC, you have to stop 2 days beforehand. If the kidney impact, you stop 3 days beforehand before that procedure. Anyone know why the duration is different?
I think it's based on the, what is it called again? The half-life.
Yeah, correct. It depends on the half-life of your medication because you want to make sure that the effects of the anticoagulants or antiplatelet is totally washed out prior to that procedure. In fact, for platelets, the half-life is as long as 7 days. So for invasive procedure, for medical procedure or surgical procedure, usually we ask them to stop 1 week beforehand. But in this guideline, I think this is a Malaysian anticoagulant guidelines, is saying to stop 5 days beforehand. So you can follow this one. For antiplatelet, you stop 5 days beforehand. Same goes to warfarin. You have to stop it 5 days beforehand. And then if you still worry, particularly for warfarin, you can even check the INR prior procedure, right now 1 or 2 days prior to procedure, to make sure that you are safe. Because in renal impairment or liver impairment, sometimes the INR can still be prolonged after you stop for 5 days. Same goes to DOAC. Most of the DOAC means it's a direct acting oral, the novel oral anticoagulant like apixaban, dabigatran, and also your rivaroxaban. Those are the newer anticoagulant without monitoring. So most of them, their half-life is only 2 days, it's 48 hours, but it's majority of them, they are cleared by the kidney. So if you have a renal impairment or chronic kidney disease, the drug will stay longer. So that's why the guidelines suggest that if you have kidney impairment, you have to stop the oral anticoagulant 1 day more before the procedure. Okay, so if you are bleeding, what do you give? So this is something you need to. These are the agent name you need to remember. Those, forget about it. Okay, so anyone know what do we give for vitamin K?
Vitamin K.
Yeah.
Vitamin K deficiency.
So we give for warfarin. Okay, so warfarin is an oral vitamin K antagonist. So what warfarin do is warfarin you bind and stop the vitamin K for taking any action. So in patient with taking warfarin, warfarinization, we'll give vitamin K. Okay, so vitamin K is a reversal for warfarin. All right. What about protamine sulfate?
Heparin.
Yeah. Okay. So the answer is here, So protamine sulfate is given to reverse the effect of heparin. Okay. So we have unfractionated heparin and also low molecular weight heparin. Low molecular weight heparin is like Clexane. Okay. The subcut injection Clexane. So you only have 60 to 80% reversal if you are using Clexane by giving protamine sulfate. So platelet you give for thrombocytopenia for low platelet, okay? Or someone receiving antiplatelet therapy, okay? Or FFP is to reverse, to correct all the coagulation factors, okay? PCC is something newer. It contains 3 to 4 factors. Usually have a factor 2, factor 7, factor 9, and factor 10. So it's useful when patient is taking warfarin, or when patient is having hemophilia, but you do not have a specific factor assay, then you can give this PCC. It's more rapid onset and lower in volume. Okay. And then for hemophilia, you have factor 7. Or you will also have factor 8 and factor 9 replacement. All right. These two, forget about it. Okay, that will be all for bleeding disorder. Any question?
Doctor, I got question. So if the person is taking vitamin K supplement, does that mean patient doesn't have to eat warfarin?
There's no such thing as vitamin K supplement. You don't get vitamin K supplement. So where do you find vitamin K? So vitamin K is something happen in natural, especially something green. If you eat green things like green leaves, all inside has vitamin K. But that doesn't mean that you have too much vitamin K, you will form clot. It doesn't mean by that. But if let's say you are taking warfarin, then you have vitamin K. Your vitamin K does not function because of the warfarin. So because of that, your INR will prolong. That's what warfarin designed to do. So if let's say patient taking warfarin, patient has a bleeding, check the INR is high, you want to reverse the effect of the warfarin, then you give vitamin K. That's what I mean for the vitamin K.
Okay, doctor. Thank you.
Yeah, and there's one additional point for vitamin K. Vitamin K sounds very benign, right? You give like vitamin to someone to reverse the warfarin effect. But there's one thing you need to remember for vitamin K is that the risk of allergic reaction. Okay, long time ago, to give vitamin K, you even have to give a test dose on. Means for that 1 vial, you have to dilute to 20 cc, and that 20 cc you have to take out 1 ml and further dilute and give over 20 minutes to watch out for the allergic reaction. It's until that extent that we worry anaphylaxis. But now this practice has been removed because it's too troublesome, too many things to do, and not that commonly seen anymore. But then we still worry of anaphylaxis because of vitamin K. So always ask a history of allergy and counsel the risk of anaphylaxis before we give vitamin K, because it's an IV injection. It can be taken oral and IV. In very mild over-organization, we give oral. But in severe bleeding, we will tend to give IV vitamin K. Always counsel the risk of anaphylaxis. Okay, any more question? So if no question, you guys want to go through the OSCE slides?
Can lah, doctor. Just a bit.
Or you guys very confident can get 100 marks? Okay, so we'll just go through the slides. Everyone just shout out the answer. The faster we go through, then we can add in earlier. All right. Okay, I haven't get your papers yet, so I don't know how you guys do. So let's see. Name the abnormality shown. What do you see on the above picture?
Proteinuria.
Okay, anyone see other answers?
Frothy urine.
Yeah, okay, if you answer proteinuria, proteinuria, I think it's very acceptable. Okay, so name 3 conditions associated with this.
Liver disease, kidney disease, nephrotic syndrome.
Okay. You cannot give me something too general like liver disease or kidney disease. It's too general. You need to give me a very specific answer. You can give me like nephrotic syndrome, yes. Diabetic nephropathy, okay.
If like liver failure.
No, liver failure itself does not cause nephrotic syndrome. It does not cause proteinuria. So liver disease is not counted. Okay. You can answer me like diabetic nephropathy. You can tell me IgA nephropathy. Those you get point.
If glomerular nephritis.
Yeah, you can answer that. GN I will accept. Okay, you can answer me nephrotic syndrome. You can answer me glomerular nephritis. You can answer me lupus nephritis. All this also will have points. Okay. Any other answer? Okay, number 3. Name 4 features of nephrotic syndrome. Okay. So can you guys name it?
This one, doctor, is the hypoalbuminemia, edema, hypertension.
Yeah, this is the
That one, right, doctor?
Yeah, I think these tips are given don't know how many times already. Don't know whether you guys can get that or not. So this means the definition of nephrotic syndrome lah. Okay, so the features will be
proteinuria, edema, ascites.
Okay,
Doc-
I will
doc-
give marks for that lah. Okay, so the feature it can be I think proteinuria already answered that now. So will be your urine protein more than how many gram, or hyperlipidemia. Patient will have edema. Okay, patient will have hypercoagulability. So those are the features that I'm looking for. Okay, question number 2. What is the diagnosis? What is the spot diagnosis from this picture?
Gouty tophi.
Yeah, okay, you can answer gouty tophi, you can answer gouty arthritis. Okay. What investigation to be done?
The first is urea level.
What level? Uric acid, okay.
Yeah.
Then anyone else is answering besides Mark?
Biferingens test.
Okay, I can accept that. If you do aspiration, you can do the light bifringen. Yes, it's okay. Yeah. What other investigation you can be done? You cannot. It's a bit far because from this spot diagnosis, it has to be gout. It cannot be rheumatoid arthritis because of the features of the tophi. So what other investigation can be done?
Doctor, how about ultrasound?
Ultrasound, no. Ultrasound will be far. But what others than ultrasound?
X-ray.
Yeah, you can do a simple X-ray, isn't it? Yeah. For usually for gout, we don't do ultrasound. But let's say for rheumatoid arthritis, then we do ultrasound. Usually gout is very obvious, so we don't do ultrasound of the joint. But if you think of a joint swelling alone, that you think of rheumatoid arthritis, then the answer is yes. Because from ultrasound, you can look at the thickening of the synovium. So that will help in rheumatoid arthritis. But in this spot diagnosis, the thing you worry about gout, you want to look at the uric acid level. You can do a renal profile. You can also do an X-ray for bone destruction. Okay. What will worsen the joint pain in this patient?
Red meat and
so
seafood.
So this basically is asking what can precipitate a gout attack lah. Okay, so you can answer whatever is logical: red meat, nuts, seafoods. Okay, then you get marks. What are the treatments for this condition?
Allopurinol and colchicine.
Okay, both also okay. But again, when I think I tell this many times before, whenever I say treatments, I doesn't mean by just medication. You can also say something. If you really you cannot crack out of a medication, you can always say something is non-medication, non-pharmacological related one. For example, will be lifestyle modification. What kind of lifestyle modification you think can treat this condition?
Avoid alcohol.
Yeah, means it's a low purine diet lah. You avoid seafood, avoid alcohol, avoid smoking. Those are things that you get marks for it lah. Okay, so be smart in answering questions. Whenever I ask treatments, you can answer like pharmacological or non-pharmacological way. Then you wouldn't lose mark by not answering enough lah. So you can do like low alcohol, avoid alcohol, stop smoking, and low purine diet. Okay, so question number 3, what is this sign called? So what is this?
Exophthalmos.
Yeah, okay, I think we went through a lot of times of these pictures, right? So this is called exophthalmos. Why we say exophthalmos? Because the eye is so huge, it's so big. You can look at the sclera above and below the eyeball. Okay. So what is the diagnosis?
Cushing. Yeah. No, not Cushing. Grave.
Yeah, you have to answer grave disease, or if you answer hyperthyroidism also I can accept. Okay. But exophthalmos is specific for grave disease. Right? What are the 3 symptoms associated with this condition?
Sweating, diarrhea, increase in hypertension.
Yeah, basically what are the symptoms of hyperthyroidism? So you answer whatever that's related: tachycardia, palpitation, sweating, diarrhea. All these will get marks lah. Okay. List the modes of treatment for this disease.
Beta blockers, the surgery.
Okay, so you can answer your medication will be by giving. You can give PTU, you can give carbimazole, then the other option will be radioactive iodine, and the last one will be surgery. Okay, yeah, again it's ECG again. Okay, so ECG will haunt you for life. Okay, so what do you see in this ECG?
I see lines, doctor. Up, down, up, down.
Okay, every time exam also I keep on revising ECG because it's very important. It's something that you need to know how to interpret, because you use it one day, you will see one ECG one day, and by then I won't be there. So you have to consult yourself. Okay, so that's why every exam also I slot in one ECG images. So by the end of the exam, of the final exam, you have to confidently tell me that where is the ST elevation, or you keep on repeating the exam. Okay. So what do you see in this ECG?
There's no P wave. That's number 1.
Okay, why do you say there's no P wave? Any other answer?
It's like not very, what do you call, prominent like that. That's why I said like that.
Okay, you look at it, this is the P followed by QRST. Okay, this is the P. Okay, this is the P wave, QRST. This is also the P wave. So when there's a P wave followed by QRST, what is this called?
Sinus rhythm.
Yeah, so this is a sinus rhythm. And then my question specifically asks for ST segments. So what is wrong with the ST segments? Okay. What are the rhythms? So it's a sinus rhythm. What about the ST segments? So in this split 1, is the ST segment normal or not normal first?
Normal.
Okay. What about lead 2?
Elevation.
Yeah, it's elevated. You look at this lead, this ST. This is the line, it's isoelectric line, the same line, so it's normal. But look at this, the isoelectric line is here. Okay, how do I? And cannot add pen. So this is the isoelectric line, this is your ST segment. So this is ST elevation in lead 2. What about lead 3?
Elevate.
Yeah, S3 is elevate as well. And then here?
Elevate.
Elevated as well. What about this one?
Depression.
Yeah, so this elevate, depression. How about here? V1?
Depression.
So there's no word. So this depressed. Okay, you see that? This one is?
Depressed.
Yeah, so you can see there's elevation in lead 2, lead 3 and VF. There's depression in V2. You can say V1, V2, and actually this is V1, V2. Actually this is depressed as well. V3 and V4. There's ST depression. Okay. Anyone that doesn't get this or not? Anyone does not understand why is it ST elevation? Okay, I hope everyone get this. If you still do not get this, you can let me know. Then we will repeat another session again. Okay, so as your diagnosis, if you see there is ST elevation,
And then STEMI. Eh? STEMI, doctor.
yeah, so it's STEMI lah, ST elevation MI, right? So it's a STEMI. So two medication to treat this condition.
Calcium channel blockers. Eh?
I'm interested in the ST elevation only. The ST depression, I'm not very interested. As long as you can tell me there is ST elevation, then I'm very happy already. As long as you can tell me there's ST elevation, and this is a STEMI, then I'm very grateful already that you can pass. Because the reason behind this is because your time is muscle. Means that when you pick up at STEMI, you have to be very quick to decide on your reperfusion treatment. Either you thrombolize the patient or you straight away go for PCI. If you delay this further, the clot can propagate, the ischemia can worsen. In the end, the patient will go into a full infarct. Means that the cardiac muscle will die due to the infarction. And that time that's too late for you to give further treatment. You have a delay or miss MI. So that's why it's very important to able to pick up the MI, STEMI very fast, and a prompt referral or prompt management is very important. So usually we see the rhythm in lead 2 lah, but this one, if you look at it, actually the rhythm is quite regular. So usually we pick the longest lead, the easiest for you to see. Okay, so if you look at this, so here to here, this is about 4 boxes. Here to here is about 4 boxes. Here to here is about 4 boxes. So if you count at it, it's actually quite regular. Okay, if you count at it, it's quite regular. Then you see there's a P wave before each of the QRS. So this is a sinus rhythm. So you only expect to know 2 rhythm, sinus rhythm or atrial fibrillation. But you see P wave, then this is not atrial fibrillation. No? So this is a sinus rhythm. Okay. Did you get that? Okay. Any other question regarding this ECG? If you still cannot answer, you just ask me, because you're not seeing this every day. That's why you take longer time to pick this out. Okay. Okay, then we move on. So I think the medication to treat this condition, everyone know?
Yes.
Yeah, so it's what? Shout out the answers. Oh, just shout out the answer, then we move on.
We have fibrinolytic agents.
Yeah, so you can.
And then, doctor, fibrinolytics. And then can use the percutaneous PCI or something like that.
Yeah, you can answer your fibrinolytic agent will be your metallase. You can answer fibrinolytic agent also as well. But you can answer metallase or you can answer streptokinase, or you can even answer something like aspirin, clopidogrel. I will accept that as well. Okay. Other comorbid associated with the above condition, I think everyone should know now. Okay, so what is this sign?
Pitting edema.
Yeah. Okay. Anyone doesn't get this? Okay, I think the picture show very well. So pitting edema. What are the common causes of pitting edema?
We have left-sided heart failure, nephrotic syndrome, liver cirrhosis.
Yeah, you can answer me heart failure, renal failure, liver failure also I can accept. Okay, so very easy, right? What 4 investigation you perform to evaluate the causes?
Renal function test, kidney function,
echocardiogram and ECG.
Yeah. So basically, you just name 4 investigation to confirm or rule out whatever causes that you mentioned just now. You talk about heart failure, you do echocardiogram, you can even do an X-ray to look for the cardiomegaly. If you worry about renal failure, then you do a renal profile. If you worry about liver failure that causing this, you do a liver function test. If you think about nephrotic syndrome that causing this, then you do a urine protein or urine dipsticks. Okay, so it's very easy, right? Okay, I think everyone can get full marks.
Doctor, I want to ask if if the gouty arthritis, right? It's
Yes.
if we put a wrong diagnosis, but then the good but then with the right treatment, would you still consider it correct?
Yeah, you're still correct.
Okay.
Okay, I haven't go through your answer sheet yet. So hopefully everyone score full marks. I think I'll only get it next week.
Okay, doctor. Thank you, doctor.
Hey. Okay, then see you guys next week. Is it next week? So any more? You guys have any more activity this week?
We have one last exam, doctor,
When is your exam?
on Tuesday.
Oh, you have another exam. Okay, good luck. Then the Thursday. Which group am I having with on Friday this week?
My group.
Your group. Okay. All right, Ken. Then I'll let you know the arrangement. Because Friday I'm not around. We'll try to arrange it. Okay, Ken. All right. See you guys. Good luck with your exam.
Thank you, doctor.
Thank you.
Thank you, doctor.